And I'm now a consultant clinical scientist at the London Spinal Cord Injury Centre, where I run the urodynamics service, the intrathecal backbone pump service, and we also have a research portfolio. So some of my interests include wild camping and cycling, and I've always done a lot of volunteering. At the moment, I'm a community first responder in some evenings in the week. And family is also very important, although come October, I'm going to have an empty nest, which is going to mean I've got more time to do all the things above. Oh, right. So I probably don't need to tell people on this call about spinal cord injury, but it's obviously a life-changing event, can be caused by trauma or disease. Obviously, it affects multiple body functions, and restoration of bladder, bowel, and sexual function are a high priority for research. I've just put some of the new numbers that Shadia from Spinal Research told us about. I think that's some new work from Spinal Research about the new numbers. So 4,200 people injured each year, and 105,000 people living in the UK with spinal cord injury. So like I say, it can affect multiple body parts, and obviously neurological, autonomic dysreflexia and pain, the urinary tract with respect to bladder emptying, incontinence, reflux, obviously the paralysis, spasticity, and the increased risk of osteoporosis, cardiovascular function, and just being able to stay fit, the high risk of stroke and autonomic dysreflexia, the gastrointestinal tract with respect to constipation, slow transit, obviously the psychological effects on skin with respect to pressure ulcers, and fertility. We're particularly interested for the project that I'm going to talk about later about the urinary tract, gastrointestinal, and fertility to a lesser extent, but they're the areas that I'm going to focus on. First, with a little bit of background about what happens in normal function, and then what happens after spinal cord injury for bladder and bowel. And like I say, restoration of bladder, bowel, and sexual function are high priorities for research for people with spinal cord injury, in a number of reviews that have been carried out. And in a James Lind Alliance priority setting partnership in spinal cord injury, bladder and bowel function came up as a high priority. And on the little table there is from a paper where they looked at all of the health priority questions and what came out top. And as you can see, bladder and bowel, and obviously upper extremity function, most often cited as the priority for research, which is why we're focusing on this, and with funding from Spinal Research. So just a bit of a lowdown on bladder and bowel function. Obviously, these are the functions that we take for granted until they go wrong, even not just if they go wrong due to spinal cord injury, but if they go wrong for any reason, it's something we massively take for granted until we can't anymore. Obviously, the normal control is attained during childhood, and dysfunction can have a huge impact on quality of life with numerous things. Loss of voluntary function, autonomic dysreflexia, incontinence. It can be embarrassing, can affect your socialization. So we can see why it might have a big impact on quality of life, and why we're so interested in doing research to try and restore those functions. So I was going to talk a bit about the sort of normal bladder function, bowel function, but I thought I'd go back to basics with obviously, most of the bladder and bowel are under neurological control, so controlled by the nervous system. And we normally break the nervous system up into things that are under conscious control and things that are under autonomic control. So our conscious control is basically the messages that get sent from the brain down through the spinal cord and to muscles, like for movement, and then the sensory feelings go back up via the spinal cord to the brain. And we also have some reflex activity which happens at a spinal level and doesn't necessarily go up towards the brain, just happens at a spinal level. And then for lots of the organs in the body, they are under autonomic control, so we have less control over them. And the autonomic control is normally split into sympathetic and parasympathetic, where sympathetic is your fight or flight response. So it's normally where the heart rate would go up, you get more blood flow to muscles and things. And the parasympathetics, we also call them rest and digest. So that's when the bladder and the bowel and things will be using parasympathetic control. So interesting, the bladder and the bowels are a few organs in the body that are under both conscious control and autonomic control. So lots of the other organs of the body don't have any voluntary control, whereas the bladder and the bowel, there is a degree of voluntary control as well as the autonomic control. So normal bladder function, what do we expect from our bladder? So we normally split bladder function into a storage phase when it's filling up with urine and an emptying phase when we're evacuating it. So during the storage phase, which is obviously the majority of the time, the bladder's main function is to store the urine output from the kidneys. It should be able to hold volumes of about up to 500 mils with no increase in pressure. It should be nice and compliant and able to stretch to hold a large volume. We should be getting sensory feedback about how much is in the bladder and when it's time to empty. But we should also be able to defer when we're emptying the bladder, and we obviously ideally are able to maintain continence. And then during the bladder emptying phase, which is sort of 5 or 6 times a day and only lasts about 25 seconds when we're emptying a bladder, we obviously ordinarily should be voluntarily able to initiate that bladder emptying at what we call a socially convenient time. So we should be able to defer it and only start it when it's socially convenient. We should be able to empty the bladder completely and efficiently, not leaving anything behind. That's what we call a residual. We don't want to leave any residual behind. And we should be able to empty it without causing any urine to go back up towards the kidneys. We only ever want urine to be draining down from the kidneys. And obviously normal bladder control is learned during potty training, sort of 18 months to 3 years. So just a bit of the neurology of bladder control. So like I said, it's a mixture of voluntary control and autonomic control. And the 3 main centers of control for the bladder are in the brain and in the brain stem, which is at the base of the brain, and also down in the sacral spinal cord. So right down at the bottom of the spinal cord. So the brain is where we get our sensations of bladder fullness and urge. That's where we can control the ability to defer emptying the bladder, and it's where we voluntarily initiate bladder emptying. The brain stem, there's an area called the pontine micturition center. So micturition is just another fancy word for bladder emptying and filling. And that is a very important area for coordinating the contractions of the bladder and the sphincters, because ideally you want the bladder to contract and the sphincters to relax. And then when you're filling the bladder, you want the sphincters to be contracted and the bladder to be relaxed. And that's all coordinated in the brain stem in this pontine micturition center. And then we've got in the sacral spinal cord, so right down low in the spinal cord, we've got something called the sacral micturition center, and that's responsible for the direct contraction of the bladder muscle, which is also called the detrusor muscle, because the bladder is basically just a large muscle, and also can control the sphincter contraction to keep us continent. So they're the 3 main areas of bladder control in the human. So after spinal cord injury, obviously the spinal cord is our main transit for the messages from the brain and the bladder. So obviously any injury to the spinal cord is going to interrupt those messages between the bladder and the brain. And obviously our bladder function after a spinal cord injury really does kind of depend on where that level of injury is. And we normally divide, with respect to bladder function, we call injuries either suprasacral, so above the sacrum, or infrasacral. Infrasacral would be the kind of injuries you might have with a cauda syndrome, but most of the talk I'm going to talk about now is your suprasacral injury. So anything from a cervical injury down to a low thoracic injury. So all the C injuries and the T injuries, and to some extent a lumbar injury. They're the ones I'm going to talk about most. The cauda equina is a slightly different situation. I'm not going to really go into that today. So what normally happens after a spinal cord injury is that we obviously lose voluntary control of our bladder function, and we can also develop what we call uninhibited reflexes. So the reflexes kind of develop that we don't have any control over suppressing. And these can lead to reduced bladder capacity, so the bladder doesn't hold as much as it used to, and meaning you might have to go to the toilet more often. We can get overactivity, where the bladder becomes very overactive and can lead to the development of high pressures in the bladder, which we don't really want. Obviously can lead to incontinence, can lead to uncoordinated voiding, where the bladder and the sphincters are no longer coordinated like they used to be. And also the ultimate thing that can happen is that we can get reflux to the kidneys, which can long-term be dangerous with respect to infections and kidney function. So this is just a little diagram of what normal bladder functions like. So the little graph on the left, we've got normal bladder function. The little graph on the bottom shows what happens to the bladder pressure as the bladder fills up. So you can see as the bladder fills, the bladder pressure should stay nice and low until we decide we want to empty the bladder, in which case we get a nice smooth bladder contraction and the bladder should empty. And the tracing at the top is EMG, so that's electrical activity in the urethral sphincter. So as the bladder fills up, the sphincter gets more and more tone in it to keep us continent, but when we're trying to empty the bladder, the sphincter relaxes completely. So that shows down as no noise on the EMG. And then obviously after the bladder's emptied, the sphincter tone can go up again. But if you look at the little picture on the right after a spinal cord injury, the bladder fills at a much lower volume. We get these uncoordinated bladder contractions, which can cause the pressure to go very high. And we can see in the trace at the top, the EMG, that the sphincter's also going contracting. So we've got bladder contraction and sphincter contraction, which may be dangerous for the pressures inside the bladder. That's what might be potentially causing reflux to the kidneys. Or if the sphincter doesn't contract, that's when we might get leakage or firing off. We sometimes call it a stanmore. So the ideal management of a neurogenic bladder, that's a bladder after spinal cord injury. Obviously during the storage phase, ideally we want to try and increase the bladder capacity back to what it used to be. We want to reduce the pressures in the bladder to control that neurogenic detrusor overactivity. We want to protect the upper tracts, the kidneys, and we want to reduce incontinence. And then with respect to emptying the bladder, we want to find a safe and efficient means of emptying the bladder that minimizes infection. Again, we want to protect the kidneys, and again, we want to reduce incontinence. So there's a number of management techniques that can be used to, first of all, to control those overactive contractions of the bladder. So the control of the neurogenic detrusor overactivity. So we can do it with drugs, with surgery, and with neuromodulation. So the types of drugs that people might be given to try and reduce overactivity in the bladder are things like oxybutynin, solifenacin, mirabegron, trospium. Surgically, we can do injections of Botox into the bladder, which effectively paralyzes the bladder. We can do surgery to make the bladder bigger, and we can do something called sacral deafferentation, which is cutting some of the nerves to the bladder. And then neuromodulation is a form of electrical stimulation that I'm going to talk about a bit more later. So obviously with all of these things, there's pros and cons to each type. So most of them are very effective, but the cons are things like for the drugs, there's quite often side effects like dry mouth, constipation. Some of them have been linked to risk of dementia. Botox, very effective, but it needs repeating probably every 6 to 9 months. And there is a potential for systemic weakness if it gets into the bloodstream. The surgery on the bladder, again, is effective, but it's quite major surgery, may require quite a long recovery. The sacral deafferentation, again, is very effective and can prevent autonomic dysreflexia, but it's irreversible and may in men cause loss of reflex erections. And then the neuromodulation, again, is effective, but at the moment there's limited availability of devices for utilising this in spinal cord injury. It's used a lot in other bladder problems, but not necessarily ones related to spinal cord injury. So that's why the project we're going to talk about later is looking at neuromodulation and how we can use that in spinal cord injury. So then for emptying the bladder, because again, we may not be able to voluntarily empty the bladder anymore, we're looking at things like intermittent catheters, so single-use sterile catheters that are in-out catheters to empty the bladder 5-6 times a day. If it's not possible for somebody to do the intermittent catheters, there's indwelling catheters that stay in all the time, so things like a suprapubic catheter or a urethral indwelling catheter. Some people do reflex voiding, so they use the overactivity of the bladder to empty into a sheath, may need to have a stent across the sphincter to stop the sphincter from preventing voiding. And then there's also, people have used electrical stimulation to empty the bladder. There was an implant called the sacral anterior root stimulator implant. And then again, we're looking at spinal cord stimulation, whether this can be used to help with bladder emptying. So again, pros and cons, intermittent catheters, easy to use. There is a cost implication and environmental impact because it's a lot of disposables that you're throwing away. The indwelling catheters are good if there's limited hand function, but they do have an increased risk of infection and they need to be changed by the district nurse. Reflex voiding obviously doesn't involve catheters, but may require a sphincterotomy, so that's cutting of the sphincter or stenting, and may need you to wear a bag all the time because they probably make you incontinent. And then the sacral anterior root stimulator implant is very effective and you don't need to use catheters to have it, but again, it's major surgery and it's no longer, I think, available in this country at present. So that was bladder control. Bowel control, again, we've got like a storage phase and an evacuation phase. So during the storage phase, all of our digested food is passed through the large and small bowel to the rectum. We normally would get a call to stool alert when the rectum should be emptied. But again, we should be able to defer this to a socially convenient time and we should be able to be continent. And then during the evacuation phase, we need to be able to empty the rectum completely and with, again, coordination between the sphincters relaxing and the contractions of the rectum to empty the bowel. So again, after spinal cord injury, again, depending on the level of the injury, we may get a reflex bowel or an areflexic bowel. We'll probably get a loss of sensation of when we need to empty the bowel. We'll probably get the loss of the ability to postpone that defecation. There may be slow transit, so things move much more slowly through the gut. May well be constipation, but equally there may also be some fecal incontinence. So the types of bowel management after spinal cord injury, initially we may be able to modify diet and fluids, lifestyle alterations and use of laxatives and other drugs. People may need to do digital stimulation and use suppositories to empty the bowel. Then we can use transanal irrigation, so like a mini enema to help flush out the bowel. Again, sacral nerve stimulation, which is a type of neuromodulation, may be useful, but not so available for people with spinal cord injury. There is antegrade colonic irrigation. The sacral anterior root stimulator implant can also help empty the bowel, and then there's also colostomy as an option for people after spinal cord injury for bowel management. So that was a quick bladder and bowel overview of what's normal and what happens after spinal cord injury. And then I said I'd describe a little bit about neuromodulation. Because I've mentioned it a few times with respect to devices and how it might be useful for restoring bladder and bowel function. But so the definition of neuromodulation is the alteration of nerve activity through targeted delivery of electrical stimulation, in this case, to specific neurological sites in the body with the aim of restoring function. So it has been investigated at lots of different sites. So things like deep brain stimulation, spinal cord stimulation, sacral nerve stimulation, tibial nerve stimulation, and dorsal genital nerve stimulation. Stimulation can be given either through surface or wearable devices, so transcutaneously across the skin, or through implantable devices. And people have looked at it for all sorts of different things. not just bladder and bowel function, but it's also used a lot for pain. So TENS machines are a form of neuromodulation for pain. So one of the forms of neuromodulation that we're particularly interested in at the moment is spinal cord stimulation. So this is very established as a treatment for neuromodulation of pain. It's safe and reversible. There have been, you've probably heard of, exciting advances in the restoration of voluntary locomotor function after spinal cord injury. And there's been some studies in the last few years looking at trying to get locomotor function back through spinal cord stimulation. And it can be done either through epidural stimulation, so these are implanted electrodes that are implanted on the membrane around the spinal cord, or non-invasively through transcutaneous stimulation, so electrodes placed on the skin over the spinal cord. So as well as looking at locomotor function, we're now looking at whether we can use it to modulate autonomic functions, including bladder and bowel function and cardiovascular function. It's not probably likely to be the cure, but it's probably most useful in combination with other therapies. So whether that's with intensive exercise or with other medications. So we did have a study running here at Stanmore that was funded by the Spinal Research. We were looking at transcutaneous spinal cord stimulation in combination with pelvic floor exercises to see whether we could get any improvements in bladder function. So that study, we split it into two phases. The first phase, we optimized the electrode positioning, where we should put the anode in the cathode. We were looking at optimization of the parameters of stimulation, so like the frequency and the amplitude. And then we were looking at the effect of that transcutaneous spinal cord stimulation on bladder function. First of all, we were looking at whether we could improve voluntary pelvic floor contractions by adding the stimulation. And then we were looking at during bladder filling and bladder emptying. So it seemed like we could facilitate, so make a voluntary contraction stronger if we applied the stimulation at the same time that somebody was doing a voluntary contraction. And then we did phase 2, we did a randomized controlled trial of transcutaneous spinal cord stimulation with pelvic floor exercises to see if we could improve bladder function. And we're just still analysing lots of the results from that. But lots of the protocols that we used in that study, we're using in the study that we would like to talk about today, which again is being funded by Spinal Research, but also by the Injured Jockeys Fund, by Nevro, and by Brain Research UK. And this is our study that's called IMPRESS. So IMPRESS stands for Improving Pelvic Rehabilitation Using Epidural Stimulation After Spinal Cord Injury. So we've got funding for a 3-year project, started this year, running to 2027. Like I say, it's been funded by a number of different charities and also Nevro, who are providing the spinal cord stimulation devices for us. We've got a large team, partly based at RNOH and UCL. We've got a mixture of neurosurgeons, spinal cord injury nurses, academics, basic scientists, clinical scientists, neurourologists, physiotherapists, gastroenterologists, and pain doctors. So we've got a large multidisciplinary team working on the project. And the main aims of the study, the primary aim is to measure the effect of acute epidural stimulation on bladder capacity and anal contractions and voluntary contractions of the pelvic floor. And then our secondary aims are to measure the effects of a 12-week home-based program of epidural stimulation combined with pelvic floor muscle training, and looking at whether we can change bladder capacity, voiding function, incontinence, colonic transit times in the gut microbiome, sexual function, quality of life, and lower limb function. So we've got a large protocol that we're working through, and lots of outcome measures that we're going to try and collect data on. So the protocol, again, this one's going to be split into phase 1 and phase 2. There'll be a screening. Then phase 1 is when a 2-week phase, when the implant will be implanted, and we'll program it for looking at the effect on bladder and bowel control and we'll give people pelvic floor and spinal cord stimulation education. And then during the second phase, people will be given a 12-week home-based epidural stimulation with the pelvic floor muscle training. And they'll come back for face-to-face pelvic floor clinics at 3, 6, and 9 weeks. We'll be obviously collecting bladder and bowel diaries. At the end of the 12-week trial, we'll again measure lots of outcome measures and have an interview about the intervention, and then again more follow-ups at 3 and 6 months, and then a final interview at the end of the study. So we'll be using 2 different types of electrodes for epidural stimulation. We can either use needle electrodes or paddle electrodes. There's pros and cons to both of them again. The needle electrodes can be inserted percutaneously, so doesn't require an operation. It's more like an epidural needle. There is a higher risk of the lead migration. It's harder to keep them where we want them to. We'll be able to get coverage of T10 to S4, but it's harder to get lateral coverage. The paddles are slightly bigger, and they're what's been used in most of the other epidural stimulation trials in people with spinal cord injury. These electrodes, because they're bigger, do need to be surgically implanted, but it can be done either under a local or a general. Obviously, slightly greater risks because we are now talking about surgery. There's better lateral coverage, but less depth of coverage, but we may be able to customize the stimulation more because there's more electrodes. So during when patients are undergoing the implantation, we'll be able to do some neurophysiology in theatre, where we'll be able to map what kind of responses we get from the lower limbs and from the anal sphincter. And then immediately after the electrodes have been implanted, we'll be able to do some bladder mapping using urodynamics, which is a test of bladder function, and also some bowel mapping, looking at sort of anal canal pressures and EMGs. So that would all be in the initial phases. And then we'll move on to the second phase, where people will have the 12 weeks of the stimulation and the pelvic floor muscle training. So we'll send people home with several stimulation programs that they'll be able to use at home, and hopefully we'll be able to target suppressing the overactivity of the bladder, facilitating voiding, trying to reduce bowel transit times, and helping with pelvic floor muscle activation. And then the pelvic floor muscle training will teach people how to contract and relax the pelvic floor. They'll be able to be seen regularly in clinic, and we'll be able to provide some biofeedback about how they're performing the pelvic floor muscle training. So again, the type of outcome measures that we'll be measuring will be urodynamics, the anorectal physiology, lots of bladder and bowel diaries, pelvic floor examinations, colonic transit times, looking at the gut microbiome to see if that changes, questionnaires, and then a global perception of improvement, which is whether people feel that there has been any improvement since using the stimulation. And then at the end of the study, there'll be a semi-structured exit interview. We're hoping that people will be able to keep the implanted device, or if they really don't want them to stay in, they can have them explanted. Participants who keep the device will have continued access to the neuromodulation service at Stanmore or the spinal cord injury service as an NHS patient. And if the participant continues to benefit from a device that then requires replacement, we will try and put in what we call an individual funding request to the NHS to see if we can get funding for a new device for them, because obviously at this stage the devices aren't commissioned for this use. This is a research study at the moment, but hopefully any useful data that we get from it we'll use to try and get it as a service for people with spinal cord injury. So hopefully I haven't rushed through that too quickly. Obviously, if you'd like any more information about the IMPRESS trial or just generally, if you'd like to contact any of these people, Hannah, Vanji or Lindsay, they're all on the call at the moment, so we can answer any questions you've got now, or do feel free to email us after this. So I think that's all of my slides I had.
Thank you, Sarah. That was really interesting. Appreciate it. Does anyone have any questions? can either pop them in the chat and we can read them out, or put your hand up or unmute yourself if you did want to ask anything.
I have a question.
Great, go for it. Thank you.
With this trial, like, have you already gone through the process of selecting participants? And also, is this trial available, like partnering with any other research institutes in other countries? For example, I'm wondering if there's anything available in Canada, or if there's someone I could get in touch with after that could help me with some connections and stuff, or some people that could provide more information on bladder function and research.
So at the moment, we're still going through getting the ethical approval. So we haven't started recruiting people yet. And it is at the moment only single site. But I think there probably are groups in Canada who are doing similar kind of work. Some of it's funded by Spinal Research, but I can't remember where they're based. So
no, Bridget, do you want to email in to us and we can find out some more information for you?
Absolutely.
Yeah.
Yeah,
you should have received an invitation emailing, an email invitation, so you'll be able to, or contact us through our website or on any of our socials, and we'll find out some more information for you.
Wonderful. I'll do that. Thank
you. There's a question in the chat, so asking if a similar trial has been carried out previously in the UK, and if so, when?
So no, as far as we know, nothing similar with bladder and bowel, apart from the one we did with transcutaneous spinal cord stimulation, but not with respect to epidural stimulation in the UK. I don't think there has been in people as opposed to in animals.
Thank you. There's a comment in the chat just about how amazing it would be to get so many of those functions regained. Definitely, Danny. Yeah, of course, as Sarah said, that's something that comes through really clearly when we talk to people with spinal cord injuries, is the difference that bladder, bowel, and sexual function could have on quality of life. So yeah, thank you. Daniel's raised a hand. I don't know if you want, Daniel, you want to unmute yourself and ask a question? Or I can, actually, I can't unmute you. No. Obviously, Daniel, do speak up if you are able to unmute yourself, because we can't hear you at the moment. Is there any questions from anybody else? There's a question in the chat, Sarah, about what are the criteria to be considered as a participant?
Okay, I have done the next slide. So inclusion criteria, we've got suprasacral spinal cord injury. So for this study, we're not looking at people with cauda equina. Age A to D, 18 to 65 years. Ideally, spinal cord injury over 12 months, but there's no any length of time after 12 months. It's just because we want people to be stable. Need to have neurogenic detrusor overactivity confirmed on neurodynamics. Part of the assessment is that we look at whether people respond to dorsal genital nerve stimulation, but that would be part of the screening protocol. Obviously capable of using the device at home, either independently or with support of carers, and obviously stable medical, physical, psychological condition as considered by us. And the main exclusion criteria, I'm going to go to a completely transected cord. If there's spinal cord injury that's related to neurodegenerative disease, any other active implanted device, if autonomic dysreflexia is not controlled, cancer, so a spinal cord injury caused by a cancerous tumour, or there's metalwork too close, Botox injections within the last 6 months, I think. Previous surgical intervention on the sphincters, recurrent urinary tract infections that are refractory to antibiotics, anything that would increase morbidity or mortality, significant pressure sores, obviously women who are pregnant or intending to become pregnant, if we don't think you'd be able to follow the procedures, or if you're participating in any other clinical trial.
Thank you. There's a couple more questions coming up in the chat about some of the exclusion criteria. There's one about why people with cauda equina are excluded.
So it's mainly due to the nature of that injury. It's called a lower motor neuron injury. We need the bladder reflexes really to be intact, and people with cauda equina, the reflexes aren't intact. So we don't think this would probably help for people with cauda equina because the physiology is different. I mean, it may do, but at this stage, the bladder physiology is very different in cauda equina to it is in a suprasacral spinal cord injury. So it may be that later, when we've got something, it would be a thing that we can try in a different group. But the way the bladder functions after a cauda equina is very different to after a suprasacral spinal cord injury.
Okay, thank you. A couple of the attendees have asked how many participants you'd be looking for.
I think we said up to 20, but Lindsay or Hannah can confirm that for me.
Yeah, that's right.
Changes in the phase 1 and phase 2 and how many we have in each of the phases. It's changed slightly, but is that right, Lindsay?
Yeah, you're right, Sarah. It's 20 recruited overall to go through both phases.
Thank you. There's a second part to a question as well that is says, would urodynamics need to be completed prior to screening, or would this be undertaken as part of the screening process? I mean, we will do urodynamics as part of the screening process. Yeah. Cool. Obviously, if it's there already, it's just helpful, but we would do our own anyway. So. There's another quite specific question from someone who says, I have a sacral nerve root stimulator. Would this trial give me any benefits? Unfortunately, at the moment for this trial, we would probably exclude you because we've got active implanted devices as an exclusion criteria, because we wouldn't want any interaction between the two devices because there already are electrodes in a similar area, and it would, we wouldn't be able to exclude that there wouldn't be an interaction between the two. There's another question again about participation. So whether confirmation from a neurosurgeon would be helpful to confirm whether they could participate. With respect to whether they've got, I guess it depends on whether it's from a urologist would be probably more useful to us, whether the bladder is a suprasacral kind of bladder, or I guess the neurosurgeon with respect to whether there's any other metalwork or what type of injury it is. Thank you. Of course, if anybody is interested in finding out more about becoming a participant, they can obviously, Sarah, reach out to the team or reach out to us, and we can hook you up to have more conversations. Yes, thank you. Yes, there's stuff there on. And we can email out the list of contact details as a follow-up as well after the session, just so that everyone who's joined can contact you if they want to put themselves forward.
I'm just wondering, Louisa, if Daniel is with us again, because I think
his hand's still up. Yes.
Yeah, rejoined the room, I think.
Hi there, can you hear me?
Yes, yes. Sorry, Daniel, we couldn't before.
Yeah, sorry. Yeah, really sorry about that. Yeah, no, I don't use this very much, so but I've made it work. Sorry, I'm a patient actually with Stanmore, and just apologies to Hannah because
Let me get to my office and.
Oh, sorry.
Sorry, Daniel, go for it.
I bothered Hannah about this a couple of times actually, but I had a few questions. So I understood it was being sort of held up by ethics approval, and I just wondered, sorry to ask again, but if there was any update on timings and when you thought you might be able to get going or start checking people's eligibility for the trial. And then, just general interest. You obviously said you did the transcutaneous study with bladder function. I'm wondering, can you give us any insights into, I know you haven't published your results yet, or just general feedback on how that went. And my understanding is epidural is sort of, it's more, or it's seen, or it's expected to be more, having more of an impact than transcutaneous because it's closer to the spinal cord. I wonder if that's true, whether you could elaborate, and also whether the sort of level of incompleteness in the injury really affects it, because obviously, like, the more incomplete it is, the more neurons you have existing there, so it reacts to stimulation. So I wonder if you're complete, whether it rules you out of there being a potential benefit. So sorry, yeah, a few questions there.
If I can remember. So with respect to ethics, that's kind of ongoing, and we obviously can't even start screening patients until we've got full ethical approval in place. But hopefully by autumn or late summer, hopefully we will be able to start recruiting, and we will have all those approvals in place. With respect to the transcutaneous spinal cord stimulation, yeah, we are kind of analysing lots of the urodynamic data. We definitely saw improvements in voluntary, even residual voluntary contractions of the pelvic floor. Even if people were only had very, very weak pelvic floor contractions, it did seem that these transcutaneous spinal cord stimulation could facilitate that and make them stronger, which was good. We didn't have a huge number of participants, so some of the urodynamic data was quite mixed with sort of different responses amongst different participants, but it did seem like we could improve bladder capacity, and in some patients we could suppress the overactive contractions, but it wasn't consistent across everybody. Some of that may be, like you say, with the transcutaneous spinal cord stimulation, it's harder to target the nerves that we want to, and also because it's surface stimulation, for some people we were limited by how high we could take the stimulation, because it did become painful if you did have any sensation. So we were sometimes limited by that cutaneous stimulation. We couldn't take it as high as we might have liked to. But I think you're right, with epidural it's more likely to we'd be able to target much better the nerves that we want to target. So hopefully we will get better results with epidural stimulation. And I can't remember what the other.
I think the last part of the question was about how complete the injury is and if that would have any impact.
So it obviously, yeah, the more incomplete, the more potential residual pathways there are to try and control, but we're not ruling out people with a ASIA A, because I think we don't really like the word complete anymore, because unless it is a complete transection of the cord, there are likely to be residual pathways still there. So I think that's why we've excluded complete transection, but even people who are classified as ASIA A complete, there probably are still residual pathways there. So we're hoping that we can facilitate whatever residual function there is still available. But yeah. But even people with a very incomplete injury who may be able to still walk around do have really quite significant bladder problems sometimes. So with respect to the bladder, it doesn't seem to necessarily be related to how complete or incomplete you are, because there are different pathways to the sort of locomotor pathways. But so yeah, even people who have regained locomotion function may well have very overactive bladders.
Thank you. Are there any more questions?
We just got one more from Bridget, who's just asking if we're able to share the recording of this meeting.
Are you happy for that?
I'm happy.
Sarah?
Yeah.
Yeah. Okay. Yeah. Great.
So yeah,
hello. Sorry,
we can be in touch.
I can't seem to figure out how to put my hand up. So
Don't
I've got a
worry. Go.
question.
Yes, please do. Go for it.
So with the epidural stimulator, if the epidural stimulator was left in following the trial, would it be programmable to do other things, or I guess following, if there's additional trials in the future, would it be future proof to allow you to, let's say this is successful, if there was ways to improve it in the future, is there likelihood that epidural stimulator would be able to kind of be adapted or reprogrammed or made more efficient in some way, based on the conversations, I guess, with Nevro was the company?
Nevro is the company, yeah. Yeah, so I mean, it is that the Nevro stimulator does have all sorts of programming capabilities, sort of, and they've got an awful lot of different functions that they seem to be able to do. And and Lindsay will know more than me whether this one has a battery so that it would need to be replaced anyway at some point, in which case it could be then updated for a newer version. But yeah, it's a commercially available device that isn't just for this study, so there would be more programming capabilities on it if it came out that from other studies or from this one there were other sort of limited by where we would be putting the electrodes, whether that would be the right place for other functions. So like if it was useful for cardiovascular, it may be that the electrodes that we've put in aren't in the right place for that, but yeah, I'm sure there would be scope in future, or just to replace it because it's sort of minimally invasive surgery.
Perfect. Thank you very much. And with the location that it goes in, obviously your comment that it's on the slide that it could be explanted, so it can be removed. Because I know that on similar to your exclusions, having it in there meant having one already in there meant you wouldn't be able to do your test.
No, I mean
it could be removed for a
be
different
removed.
trial in the future.
Yeah, absolutely. Yeah.
Amazing. Thank you very much.
No problem.
There's a question that's come up just about sharing slides as well, which Sarah,
Yeah, no,
you're happy to do that too? Obviously, like no pressure if you don't want to, but yeah, so we can share afterwards. Okay. Is any more questions? If there's anything that you think of and you want to reach out to us at Spinal Research, obviously you can get in touch via our website or via our social channels should you want to ask any, if you think of anything after we've left the call. But if you do want to ask anything now, then please don't be shy. That's what we're here for.
Hello.
And some of the research team are also on the call. Oh, hi, Mike. Some of the so Lindsay and Bandy and Hannah are also on this call. I don't know if there's anything they want to add about the study. So realise I'm speaking on behalf of all of them. So.
Hello.
Hi, Mike. Did you have a question?
Mike. Yes.
Don't ask me a hard one, please.
No, I'm sure it isn't.
Mike was my boss
I'm
for
fascinated.
many years.
I'm fascinated to see how far you've got with this project. It's great. But I was going to ask you about improving the efficiency of voiding.
Right.
That one of the techniques that has been thought through in the States and over here now is the idea of blocking the pudendal nerves in order to get more efficient emptying. Are you planning to include this sort of technique into your study?
So it's not one of our primary outcomes at the moment, but we obviously will be monitoring so it's not going to be our main focus, because our main focus is going to be increasing capacity and reducing NDO, but we will be measuring voiding efficiency. And obviously we're kind of limited by how much experimentation we can do on people who volunteer. So that's why it's not our primary focus, but it's obviously something that we are interested in. And it may be that the spinal cord stimulation can reduce some of that DSD, as you know. And obviously, we're not going to not look at it, but it's not our primary focus, just because we do have to focus on other things, and at the moment it's the capacity and the reducing the overactivity.
Yes, my understanding is that at Bath they're planning to do something similar, not like your project, but doing the blocking of pudendal nerves in order to.
So obviously we won't have electrodes on the pudendal nerves, it's all going to be spinal cord stimulation, but we will be measuring voiding efficiency as an outcome measure.
Sorry, but a question in the chat from Jenny, which I'd like to know this too.
DFD,
what that stands for.
So it stands for detrusor sphincter dyssynergia. That's where you get the bladder contracting at the same time as the sphincter, which is what will mean that you might get very high pressures in the bladder, because the sphincter should be relaxed when the bladder's contracting to empty, and doesn't, because we've lost that coordination, which is up in the brainstem, the thing that coordinates bladder contracting, sphincter relaxing, or sphincter contracting, bladder relaxing. So DSD, detrusor is the bladder, sphincter dyssynergia, because they're no longer working in synergy.
Thank you. Okay.
Thank you.
Are there any more questions?
Sorry, I've just thought of another one. The
Go
fellow who
for
can't
it.
put his hand up. Sorry about that.
No, go for it.
Is there any thoughts on sexual function with regard to this trial? Is there anything in there to do that, or will it be just a kind of any comments on that will be recorded, I guess?
So we're going to record any changes in sexual function, but again, like initially, because we have to be quite careful about having kind of primary outcome measures, it won't be our primary one, but we will be recording whether people report any changes. So we've got some questionnaires that do look at sexual function. But yeah, we won't initially be kind of focusing on it, but if there's like secondary effects, then hopefully we will pick them up.
Perfect.
You have
Thank
to
you
be
again.
careful that in a 3-year project we can't kind of cover everything.
Yeah. We just have a keen audience.
Yeah, I know, I'm sure. So I mean, hopefully with some of these things will come out as kind of corollary effects, and then we can maybe get funding to look at them in more detail afterwards. But we kind of have to focus on very specific, particularly for the ethics application. We have to be really clear about what our outcome measures initially are. So we sort of have to focus on a few.
Thank you. So any last call for questions? And otherwise we'll let Sarah, thank you so much. We'll let you go. Sarah, thank you very, very much for sharing that with us. Obviously, as I said, if you do have more questions, please do get in touch either with us or if you're interested in the trial itself, please do get in touch with anyone in the team, as Sarah's got the email addresses up there, which we will also share out with you all. If you are also interested in the neuromodulation and the spinal cord stimulation piece, we are going to be sharing a recording from one of our partners who are called Onward, who have been doing external spinal cord stimulation. They've developed a system to do that, and they've been doing some really interesting trials in Canada and America. So they've got a really lovely film about that we'll be sharing at a session soon. So keep your eye out for that, and you can come along and listen to them talking. And they've also got a couple of people who've been part of the trial that talk about their experiences as well. So it's really interesting content. So keep an eye out for that, because we'll be inviting you to that soon. So thank you. It's really useful, Sarah, and the rest of the team as well. Thank you for joining. Thank you everyone for coming along, and we'll see you all again soon.
Thank you.
Thank you. Bye-bye.
Bye.